get started with hopefully a motion to approve. Yes, I'm sorry.
I just had a thought. If some folks have set their calendar timer to come at 11:25 and we've done it at 11:15, does that take away their opportunity to make a comment?
Yeah, I think it's a really good call out. We've, just to give you a little bit more detail, we've struggled a little bit with that. We've heard from people that they prefer to comment after they've heard the meeting. If you remember, we used to put it at the beginning, so it was a very predictable time. So now that we've moved it to the end, there's a little bit more, I think, squishiness there. So
I totally understand. But let's see how it goes. And folks, if you're watching the meeting now, you'll go early. So that's great. Thanks.
Yeah, well, and oftentimes we do run over, so it's possible that we'll be right on time at 11:25 with public comment. But I appreciate the question and the feedback, and I think we can continue to work towards solutions for that.
Great, thank you.
Yeah, thank you. So yeah, and Margie is advancing the slides. So Margie, if you want to go ahead and do that, that would be great. So Margie,
I just moved the slides. Can you see the agenda page?
No, we're not. We're still seeing the title page.
Oh, that's weird.
Always, it wouldn't be a meeting without some technology glitches, right?
How about now?
Nope, we're still
I just
seeing
see
the title page. Is everyone else seeing? Okay.
No, I don't even see the title page. I just see it's a black screen with FM in a circle. I don't know if everyone else sees that.
Well, that's weird. I can see. I'll try it again. Hold on.
Yeah, that's great. Sometimes if you stop sharing and start again, it helps. And Karen, I see you have your hand up.
All right, can you see it now?
No.
Oh dear.
I just wanted to introduce myself, Karen Virtue, also a member of the MAC.
Oh, Karen, I am so sorry. I saw you checked in and I missed you. My apologies. That is my fault.
And we did not have any snow or ice here on the coast, so we've stayed nice and warm in the 50s.
Well, you're the envy of the rest of Oregon.
Can you see the screen now?
Yes, I can.
Yes.
Oh, okay. All right.
All right. So, Karen, I'm glad you stayed warm and you well kept power and didn't know what it was like to be powerless for a couple of days, or multiple days depending on where you lived. So looking at the agenda that we have, a pretty packed agenda, a few changes, and for me, I apologize in advance. I think after the break, I'm going to be a little less present. We have some all staff things that we're doing at my company that I have to be a part of, but I'll still be on the line. So I think I'm going to facilitate the first part of the meeting. We'll talk about healthcare interpreter report findings and get an upgrade on the telehealth work group, substituting the DHS update, like Jackie said, for an update, I think, from the Consumer Advisory Committee, and then OHA update. And then we will go into a break and a quality strategy discussion, an update. I think that advancing consumer experiencing is going to be up around 10:10, and then Leslie will cover what happened at the OHPB retreat, and we'll do public comment and hopefully wrap up by 11:30 or so. Margie, if you want to go to the next slide. So we got to approve some minutes. I'm not sure if folks had a chance to see the minutes and if anyone has any comments, but do I have a motion to approve minutes from the January meeting?
This is Adrian. I will move, but can I ask for a suggested edit or follow-up to the members?
Absolutely.
To the, yes.
Just noting in the minutes that for the encouraging MAC members to participate in the health policy board's retreat, if we could get that date added, or information on when that information will be sent to MAC members.
Yeah, I'll give a quick update on that. That retreat was last week. It took place over 2 days. There is an additional Oregon Health Policy Board meeting next week, and I will send the information for that. We talked about this briefly in our last meeting. I apologize that that information was not clear.
All right. Do we
So
have
if we update the minutes to?
Yeah.
If it's possible,
So, I
update
don't
the
know if
minutes
you
to say when that meeting already happened. Is that possible?
I'm sorry, Adrian?
Is it possible then to just add into the minutes that that meeting has already been completed for that retreat?
Sure.
And
Yeah.
add the date?
Yeah.
Thank you.
So
and
we
just
have,
this is Leslie, so just the minutes are reflecting what was discussed at that meeting. I see what you're saying, Adrian, so we appreciate that. And I will go ahead and second that motion.
Great.
yeah, with the motion. Okay, so just quickly, any further discussion? So all in favor of approving the January minutes with that slight amendment, please say aye.
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 Opposed? And abstaining. Miguel, I saw your hand shot up there. Do you have anything to add?
No, it was the I. No, it was nothing.
Okay. All right. Just a nervous twitch. Okay, so we will move into our health interpreter report findings. Quickly, Wilson will share findings from this initial healthcare interpreter report, which is related to the equity measure for meaningful language access to culturally responsive healthcare services. Just over a year ago, the Medicaid Advisory Committee submitted a letter of support to the OHPB and the Metrics and Scoring Committee to include the meaningful language access measure in the 2021 CCO Incentive Metrics Program. I think findings from this report are important to the Medicaid Advisory Committee's role in monitoring CCO 2.0 implementation from a consumer perspective. We think this report creates some visibility into how the Oregon Health Plan members are receiving culturally and linguistically appropriate care. So with that, I want to turn it over to OHK and Quickie Wilson.
Thank you very much and good morning. I want to begin by thanking you, Jeremiah, as you just mentioned. Your support for this measure was very important, and we also know that there's strong evidence suggesting that this actually improves members' experience. Not only that, but it drives access and outcomes. So thank you for that. My name is Quickie Wilson, and for this presentation, I'll just focus on evaluation of the reports we recently received from CCUs. So the purpose of this presentation is to share our summary results and discuss your feedback and questions. The presentation will highlight the CCO contract requirements, a logic model for the interpreter services and requirements, our evaluation criteria, the results we found, which are initial results, and the lessons learned. Next slide, please. So there are two main contract requirements. And the first requirement is an annual language access self-assessment. And this is designed as a survey, and it's due to OHA from CCUs on the third Monday of each January. And we just recently received these reports from CCUs. And the second requirement is a quarterly utilization of language access services. And this requirement, CCUs will have to provide monthly detail on members who needed interpreter services and received those services. And this report is due on the third Monday of the fourth month of each quarter. This is a quarterly report. So these are the two main contract requirements, and this evaluation is based on those requirements. However, due to the COVID-19 exemptions, CCOs were allowed to submit 3 results reports in block, and this was done closer to the end of October last year. And again, those are the findings that this presentation would focus on. Next slide, please. So the goal is to evaluate meaningful access to healthcare services for CCO members who need spoken and sign language interpreter services. So that is a primary goal of this requirement in the CCO contract. And I often have this question asked, what do you mean by meaningful access? And we borrow from this Department of Justice definition, which is access that is not significantly restricted, delayed, or inferior compared to programs or activities provided for English proficient individuals. And I think this drives from the argument that it improves, for this particular population, it improves the experience. So next slide. So this logic model provides a consolidated and clear view of how the CCO 2.0 policy recommendation, the key resources and activities logically lead to desired short and long-term outcomes for this particular measure and requirement. So the requirements are derived from the Policy Board's recommendation 3B, which we cite here. And based on this recommendation, 2 separate reporting streams were developed and implemented last year. One was a contract reporting requirements, which I mentioned. And the second was what you help us get over the finish line with, which was adopting this as a health equity measure and including that in the CCO incentive menu set, which was with your support metrics and scoring approved last summer. So we're due and in track to begin to do that incentivization of this work. So our intent there is in the short term, we will track how CCOs and their network are providing quality interpreter services by measuring the proportion of member needs for interpreter services that are provided by working with OHA qualified or certified healthcare interpreters. And in a long term, we expect that improvements in quality interpreter services would help to eliminate inequities in access and outcomes of care for limited English proficient and deaf and hard of hearing members, and help translate into triple aim gains. And there is strong evidence suggesting that this path to improvement is in fact possible. Next slide. So this slide shows a standard remediation level matrix and serves as a framework for evaluating all CCO 2.0 requirements and deliverables in contract. This was developed by the Health Systems Division in OHA, and the metrics provides a common way to communicate results and allow for easier long-term evaluation, and as well as individual CCO progress. So in the first column, the R levels define approval levels and whether corrective action, including potential financial penalty sanctions, are appropriate based on an evaluation of a CCO performance. And as you see from the next column, an R0 suggests that there are no compliance concerns. And if you go to the extreme 3 columns there will be no corrective action if the R level determination is R0, and there will be no financial penalties. However, if you move down to R3, you realize that that designation suggests that the financial remediation is required, maximal remediation is required, and there are health and safety concerns. And again, there would be some corrective action there, and penalties and sanctions are all likely. The small r is when a CCO's performance continue to lag behind expectations, and that will be tagged on. And so this was the primary approach to our evaluation. Next slide, please. So this slide shows a summary of our evaluation and scores. And for this evaluation, we created a composite score of 10 points based on the following: whether the proportion of member visits needing interpreter services each CCO identified served, and reported. We also looked at the proportion of such visits each CCO worked with OHA credentialed, qualified, or certified healthcare interpreters. And then the third was the quality of the CCO report, whether the data CCO submitted met the stratification criteria we included in the reporting template. And this result suggests that 5 CCOs scored 9 points or above, but no CCO had a perfect score. And for the CCOs in this group, we concluded that there are no compliance concerns, but there is room for improvement. 5 CCOs scored less than 9 points, and their scores were greater or equal to 7. And we identified minimal concerns for remediation and improvement. 3 CCOs, scored 7 points. They were less than 7 or greater or equal to 5 points. And for such CCOs, we identified moderate concerns for remediation and improvement. And the last was 2 CCOs scored less than 5 points, and we identified significant concerns for remediation and improvement. However, due to the novelty of this level of reporting and expectations, the CCOs will in fact improve the service delivery and reporting through a learning collaborative that we are putting together beginning this Friday, and through other technical assistance and potential tweaks to the reporting specifications. We recommended that especially CCOs that scored very low in the error levels should not be sanctioned or penalized at this time, but we expect that they will, and we provided 15 different feedback to each CCOs. So for them to integrate our feedback and potentially resubmitting their report for another round of evaluation. And this is all in the spirit of this glide path approach to improving the services availability, the availability of interpreter services for our CCO members. Next slide, please. So this chart shows the interpreter utilization levels for members who needed interpreter services. And so general interpreter services, and specifically for members who receive the visits through telehealth. So the 15 CCOs are there, and in no particular order, so not showing anything on that. But the blue line tracks the proportion of total visits which members needed interpreter services, and CCOs worked with OHA qualified or certified healthcare interpreters to provide. This is an important area, and as we move to the incentive phase of this work, that will be where we would use this to benchmark and assess improvements over time, whether CCOs are in fact working with qualified or certified healthcare interpreters. The orange line tracks the proportion of total visits provided through telehealth with when CCOs worked with qualified or certified healthcare interpreters. And so you could see a summary point in this is that at this point, CCOs, or at this stage in this work, CCOs are not working in terms of the proportion of qualified and certified healthcare interpreters they're working with to provide services for members either through telehealth or in the regular in-person or other modalities is very low. And we hope through our efforts to bring this up, if we consider that this is supposed to be available for every member, then we're expecting to see CCOs scoring at least in the 80% or beyond, but we are barely approaching 40%. So we have some work to do here. Next slide, please. So this captures our lessons learned from this evaluation of 3 reports. We realize that CCOs are making progress, but they are not where we expect in terms of consistently working with qualified or certified healthcare interpreters and reporting that back to us. So CCOs are able to identify additional members needing this service, which is good. And they're collecting and reporting stratified data to OHA, but they're doing so at varying levels and with degrees of success. They're identifying gaps in workflows and working to address them, which are all good. There are opportunities for improvement, however, in terms of capturing and reporting data on the types of services and the settings where members received interpreter services. Identifying the types of services members received, as well as capturing and reporting data on the credentialing of the interpreters who worked in CCOs to provide these services. Next slide, please. And there are challenges as well. And the main challenge we've identified is the data lag. CCOs most of them use two sets of data, either claims or invoice from their contractors as part of this is contracted. And there's a data lag there between 90 and 120 days. We are asking CCOs to report this data back to us in a 90-day cycle in 3 months. And it appears that that needs to be addressed, and we're working to address that. There are concerns or problems with matching data from invoice, because the invoices that CCOs receive from their vendors do not include all the data elements we're requiring them to report back to us. And so that is also an issue we're working on. Not all CCOs can identify members needing the services during the intake, and that sometimes leads to some members falling off and not getting the services. Some CCOs, in fact, can identify additional members, but not all of them can. And on OHA's table, we have been unable at this point to validate the additional members that CCOs identified because there is the 834 form that OHA sends to CCOs that includes a flag, and there are instances where the flag has not been there, but the member needed services. And when they receive the service, OHA has not been able to validate that. And again, we're working on fixing this as well. I think that ends this slide. And thank you for your time, and I look forward to our conversation. And I think that one point that I want to drive home is that this work, we think it's very important to improving a member's experience, because if you cannot communicate with your provider, it leads to so many unintended consequences. And so we sincerely appreciate your support for this, because it drives members' experience and would lead to us reducing inequities in access and outcomes of care. Thank you very much.
Thank you. That's a fantastic presentation, and I think it highlights some of the things I know with my CCO hat on that we've been trying to deal with. And I think one of the things from the CCO world that's been tough is really trying to lean into this work as the state sets up new guidance, or not really guidance, but kind of expectations. And CCOs are trying to figure out the right way to kind of build something from scratch. It's not, I don't think it's something that a lot of managed Medicaid has had in place, or we're also trying to do a lot of other things. And so I think what we're starting to realize is really that we're just scratching the surface of what meaningful language access should look like when it comes to interpreters and lining that up. But it's not as though there's an infrastructure there to build on. We are also building that infrastructure, simultaneously, and working with, I think, data systems that are hard to work with. I think we're also in just a little bit of a rabbit hole, but I think one of the things around meaningful language access that's interesting is also connected to like how we capture real D data, right? And how we communicate with other CCOs, our members, and then the state who we're serving, and how quickly we get that data back and forth between the agency has a huge impact in our ability to address what disparities we may see based on marginalized communities or communities of color. And we got to play the cards we're dealt right now, and it's not as seamless as it feels like it should be as far as collecting that data, as far as doing that without being abrasive to providers, as far as getting that information to OHA in a way that can get validated quickly, so that we can all use that in an actual time to make an impact on these communities that are under this general idea of equity, right? And I think where this presentation to me resonates the most, and what I'm happy about seeing, is it shows how much work there is to do, and how much I think probably partnership and collaboration needs to happen to really do this work well. It's really, I feel like it's really kind of starting from the ground floor here. So thank you for that. And got a few hands up. I think start with our co-chair, Leslie.
Hi there. Thank you so much. This was really an eye-opener for me. As a provider for a high-risk population, we use interpreter services all the time. So I was really surprised at the low percentages and the work that's ahead of us. So thank you for that information. You mentioned a training that's happening this Friday. Just a clarification, is that one of many that are going to be ongoing as we ramp up to help the CCOs reach the metrics that we need for our patients?
Thank you for your question. Yes, at this time, and it's more of a learning collaborative that we are calling this, because we realize from this report and from other conversations that CCOs are at different stages of this work. And as you all know, and Jeremiah alluded to, there isn't much around the country to look at and say, okay, we're going to steal, quote unquote, and use. So we are actually working from the ground up, and a lot of states are actually interested in what we're doing. So we're bringing CCOs together in a collaborative environment to share knowledge and bring in additional experts to inform our conversation on how we move this work forward. And so for now, we have about 5 of them monthly beginning this Friday, and we'll care monthly to the early summer. Based on how that work and with potentially funding available could expand that. Again, it would also depend on where CCOs are at the end of the first wave of this collaborative. We have 4 of them scheduled at this point, so there'll be 4 for now. And we send out registration links. I don't know if you received them, and if you're still interested, we just closed that because there are about 100 people. We weren't expecting that, but we could potentially see if we can target, including a few additional providers. So Jackie knows where to find me, unfortunately. Yeah. Unfortunately. So please let us know if you still want someone in your outfit to participate. I think we can make that happen.
Great, thank you so much. And you answered my additional question of how many are signed up. So thank you very much.
Thank you.
Yeah, I think there's pretty great interest. And really quickly, when is the 4th collaborative going to wrap up? What's the timing of that? When they'll all be done?
Quicker.
I think you might have got on mute.
Yeah.
Sorry. You think we can figured out how to do this? We're still learning. Sorry about that. I think the last one will be the end of May or early June. I will check and let you know, but I think that's where we have the last one for this wave. And we have actually started thinking about, because of the number of people who've registered, potentially extending this. So we're thinking about where we can find sources to do that. But at this point, the last one will be either the end of May or early June, and I'll confirm that date.
Okay. Miguel, I know you have your hand up, and then after Miguel, we'll go to Tammy.
Thank you so much. So this is Miguel Angel Herrada. So in your second page of findings, you were reporting that some CCOs can identify member needs from their intake data. Could you expand a little more about that? Because I had the impression that the data that CCOs use is that the data provided by OHA, but this makes me think that there are CCOs that are successfully combining other types of data. Could you expand a little more on that, please?
Sure. So from onset, we informed CCOs through our communication that relying only on the information that comes to CCOs from OHA through the 834 form will not be enough. And there is a need for additional data sources to identify member needs, either at the intake or in other areas. Some CCOs are using census data, for example, to try to capture some of this need from their communities they serve and the members there. And so that is the additional way some CCOs have used to track the needs of the members and make sure that they're not only relying on the 834 form because it undercounts the need at this point. Does that help?
Well, not really, because census data, it's even more, I mean, from a minority standpoint of view, we know that not all people report full information on census, particularly what happened on the last administration. So my hope is that we found a way to share information with the providers, because we know that they have a much more complete information. So relying on census data, I don't know.
I agree with you. I just gave that as an example of an additional data source. We also know that some CCOs, through their community engagement efforts, have been able to identify additional members. It's just that we think that relying only on the 834 form is not enough to capture all the need.
And we have talked about that on this table before, about thinking, so the need for OHA to develop a better intake form, more complete, more accurate, to from the beginning capture the needs of the members. And so really, we hope that eventually OHA will take the lead on that and review the intake form that they use for Medicaid members. That's a need. So yeah, hopefully we can advocate for that change.
Yes, thank you for that. And in the last slide, I said that we're trying to do something on that as well. And what we're doing at this point is working to see whether we can quickly, as CCOs, identify additional members. Again, with the idea that we want to update the forms and the information about member needs. If CCOs identify additional members, we are aware that it takes quite a bit of time to be able to update the OHA information to reflect that either a member had this need but was not previously identified, or that they were previously identified but no longer need the service. So it goes both ways. And we're working to streamline that process. And I think that also will help to, if you will, clean up the data a little bit. But I share your concern that there is more that can be done to update that information. Yes.
So I want to be a little conscious. Thank you for that, Miguel. I want to be a little conscious of time here. We're at 9:40. We've got two more questions, one from Tammy and then one from Divya, but we need to be fairly quick. So, Tammy?
Okay, yes, thank you. And Miguel, you got to one of my questions. Thank you. This was a very eye-opening presentation, very helpful. Did leave me with lots of questions, so maybe I can follow up later. But I would like you to talk a little bit more about the glide path approach to correction, if you would. That went by me fairly quickly. Did I catch it correctly that none of the sanctions or the fines are being used at this time for those that did not meet the standard?
Yes, and if I can add a caveat there, the decision, in fact, is above my pay grade, but that is a recommendation we've made. And at this point, we think that, I use we for the evaluation team, we think that suggestion is being well received, and so potentially there wouldn't be any punitive consequence at this time. And that also suggests that CCOs will accept this offer to integrate our feedback and resubmit and demonstrate improvements in that area as well. And so that also speaks to this glide path approach to this work.
Thank you. And so with the learning collaboratives, then, if that's part of the solution, it sounds like, are you convinced that the people at the learning collaboratives are those that have the ability and the teeth, so to speak, to make the corrections needed?
Not sure how to answer that question, but I have reviewed some of the people who have so far registered. And I would say, yes, for the most part, they are the people I have worked with in this area. And so seeing them registering for this suggests that that work is continuing. However, I'm unable to say that everybody who's registered, in fact, can move this work back in their organization.
Thank you.
All right. Well, thank you all so much. I know we have one more question from Divya, but I think we may try to handle that by email to stay on track. But we thank you again for coming. We appreciate this report. Obviously, there's some serious interest, and I also am glad to hear that there's people that are signing up in waves for the collaborative too. I think there's a lot on a lot of sides of this issue that are trying to resolve it, so and improve it. So thank you.
Thank you very much for your time.
Just a quick reminder that if you are not speaking, can you put your phone on mute so that we can hear others? Thank you. Next, we're going to go to a telehealth work group update from a Medicaid Advisory Committee alumni, Amanda Peden. Hi, are you there?
Now
Amanda,
I'm on. Now I'm off mute. I'm here.
Now you're up.
Hello.
Okay, so in 2020, yes. Hi, great to see you.
Hello. Great to see you.
In 2020, COVID necessitated rapid policy changes to support telehealth use and reimbursement, and Amanda is here to share data about telehealth utilization, barriers to telehealth use, work underway, how her kids are doing, how much she misses us, etc.
Et cetera, et cetera. Well, thank you, Jeremiah, for that introduction. And yes, I'm Amanda Peden. I use pronouns she, her, hers, and I did have the honor of staffing the MAC from 2016 to 2019. And so it's really nice to see you, Jeremiah, and other familiar faces. And excited to talk with you all today about telehealth. And I am a senior policy analyst with the Office of Health Policy at OHA and telehealth lead for health policy and analytics. And one of my roles is to staff an internal cross-agency work group that's focused on telehealth. And it's a work group that started back in the early days of the pandemic and continues to meet to really work on cross-agency coordination and alignment of all our various programs and policies in telehealth, and to really work together towards a common future and vision for future telehealth policy. So next slide. Today, I want to start by talking with you all about a little bit about just the story of the rise of telehealth use over the past year and what we've seen particularly in OHP, and then also share again how we're working internally to coordinate and align our telehealth strategy towards more permanent policy, really recognizing that telehealth is here to stay. And I'll sort of frame my presentation focusing on kind of three key themes of where we feel we're going next in terms of equity, data, and coordination and alignment. So next slide. So first, I'm going to start with talking again about telehealth and COVID-19. Prior to the pandemic, telehealth use in Oregon, Medicaid, and really across the board in the health system was extremely limited. But when COVID-19 hit, the Oregon Health Plan really plunged into relatively uncharted waters, and telehealth services spiked. So this was supported, as you can see here on this slide, by various policy changes to really support the rapid uptake of telehealth and transition to telehealth. In the Oregon Health Plan, we increased both coverage and reimbursement, so paying parity, paying the same rates for video visits and phone visits as for in-person visits. We also worked really closely early on with the commercial insurance regulator in Oregon, the Department of Consumer and Business Services. And under the governor, really the governor's office obtained these voluntary agreements with commercial health insurers to increase coverage and reimbursement. Recently, OHA joined these insurers again to extend coverage through June of this year, and now, as I sort of allude to later in the presentation as well, with the likely extension of the public health emergency through the end of the year, Medicaid coverage and flexibilities around telehealth will remain in place as long as the public health emergency is in place on the federal level. And then finally, some licensing boards eased regulations on out-of-state providers so that they could provide, so those who maybe live, just over the border in Washington or other states can provide telehealth services to Oregonians. And that's, of course, particularly helpful to Oregonians also who live near those state borders and might get their health care across the border typically. So next slide. Oh, great. Actually, that's great. Thank you, Margie. This chart really visualizes the effect the pandemic had on telehealth visits for within CCOs and fee-for-service. So the top line you see is the CCO program, and then fee-for-service, the bottom line. And as I think most who are in this audience today are very familiar with, the vast majority of OHP members are enrolled in CCOs, about 90% of members, and so that explains the much higher line here for CCOs, just to make that clear. But what we really see here is that telehealth visits in the Oregon Health Plan increased by 40-fold or more, really soon after Governor Brown declared the emergency order in March of 2020. These peaked in April, but they're remaining significantly higher than pre-pandemic levels even now. And while this data is still preliminary, it's less reliable, especially in the more recent months because of a lag in when claims are submitted and received. We're still noticing that levels seem to be kind of going down a bit over the summer and perhaps leveling off, but we were seeing additional peaks again, small peaks in the fall months, which suggests demand really may largely sustain throughout the public health emergency for telehealth. So next slide. And this is just another, this is data from the federal level. And just another kind of picture from really early on in the pandemic. So this data only goes until June. But really you see here that regardless of even practice size, there was that initial spike and then a leveling off, but still telehealth levels appearing or sustaining much higher than prior to the pandemic. All right, and then just to dig a little bit deeper into where are we seeing telehealth and what kinds of visits are most common, this table looks at the most frequent diagnoses in behavioral health for telehealth visits and then in physical health for telehealth visits. And you can see that for behavioral health, which behavioral health visits in general have really spiked on the telehealth side. And that, of course, can be for a number of reasons, but some of the reasons may be because the increased flexibilities and payment for telehealth visits have really had some significant impacts on enabling more people to get their behavioral health care through telehealth, and it can work really well for some people. So here you see that, especially for opioid use disorder treatment, post-traumatic stress disorder, and generalized anxiety disorders, that those are the three most common behavioral health visits in the telehealth side. On the physical health side, visits for hypertension have been topping the list, followed by contact with and exposure to other viral communicable diseases. And that's actually a code that's being used for suspected cases of COVID-19 prior to testing and diagnosis. So it makes sense that is very high right now. Next slide. So despite this rapid increase that we've seen in telehealth use, we know that telehealth isn't working for everyone. And that for many people, there are still really significant barriers that need to be addressed to ensure that we have equity right now, while we continue to have social distancing measures, and then also as telehealth moves forward. And OHA has heard feedback from members and community partners really from a variety of settings at this point. And these are some themes from that various feedback that we've had. A lot has come up during the community outreach and listening sessions related to COVID-19. Our community partner outreach program hosts monthly conversations with community partners that help to, many that help enroll people in the Oregon Health Plan, and telehealth has been a common topic, and the Oregon Health Policy Board has heard about telehealth over the last several months. And what we, and we've also had a listening session in the fall, I should mention, and I believe we may have included in your packet a link to that summary listening session, but I'm happy to share that information. What we really, some of the themes that we've heard are that people, and these, are likely very expected by many. Many people in Oregon don't have fast or don't have affordable internet service, and may not have access to devices, may not have phones or computers, may not even have electricity or outlets for charging those devices, even if they had them. So obviously some really big immediate barriers to how do you then access an appointment if you don't have the technology. Others are unsure how to use the technology. Some don't have a private space or a safe space for a phone or video call. Some people, as you just heard from Kweku's presentation, some people have had a hard time getting an interpreter, and getting healthcare by phone or video simply isn't acceptable for some cultures, isn't appropriate. And so we know that as we move forward, and right now, we need to make sure that people still have access to the care the way that they need it, and also to solve some of these barriers. Next slide. And this is just a slide to show that on the provider side as well, we know that providers are experiencing firsthand some of the stressors of their patients not being able to access telehealth. This is some data from a national survey of primary care providers from the Larry Green Center, and shows patients being unable to use telehealth as really one of the consistent stresses that has been cited by Oregon participants. Not on the other hand, we hear a lot from providers about the amazing impacts of telehealth in actually improving access for many of their patients, and people who have previously had barriers to childcare or transportation or other barriers finally being able to get healthcare now. So just want to share both of those contexts. Next slide. So now I want to move into talking a little bit more about how we're thinking about moving forward with telehealth, as there's really this national consensus that it's here to stay as a really important part of the delivery system and an important way of accessing services. So next slide. So since talking with the Medicaid Advisory Committee, really want to focus in first on the Oregon Health Plan, and this work to move towards permanent telehealth policy is really well underway. OHA made significant expansions, as you saw in the early months of the pandemic, via emergency rule, but this fall we're working towards developing. We worked towards developing more permanent policy. We had a stakeholder engagement process through a rules advisory committee and public comment, and developed this set of rules that went into the effect actually at the beginning of this month, or we're in February now, at the beginning of January. The new permanent rules reflect really a set of services that were prioritized by the Health Evidence Review Commission, which, as you all know, I think reviews the clinical evidence in order to guide OHA in making benefit-related decisions for health plans for the Oregon Health Plan. And with the new rules, our approach has really been to continue many of the temporary policies that were put in place initially with an eye toward treating telehealth more like a mode of delivering services where clinically appropriate, rather than a service in and of itself. So just as some examples, the new rules allow patients and providers to engage in telehealth from home. That will continue to be the case. Providers are, of course, required to have a permanent space or a private space to conduct those visits. Covers telehealth for new patients, in addition to patients with established relationships with their providers, and requires pay parity for telehealth visits. I will say that current rules that include pay parity for audio-only services, this is one area in particular, so phone visits, one area in particular that OHA is following closely, and during the stakeholder engagement process for the new permanent rules, there was general support for the rules overall. There was some substantive feedback, particularly related to phone visits, and ultimately, we are really monitoring a lot what is happening on the federal level, and what will be happening in terms of what we'll be hearing in terms of the evidence and seeing as we move forward with all policies around telehealth. Next slide. So, and I'm going to move a little bit more quickly here because I really want to leave time for questions. But in terms of moving forward as we continue to refine some of the policies and programs around telehealth, we kind of know three things. First, we know we need to center equity. We know we need to focus on access for priority populations, acknowledge and address barriers that we see to telehealth, and really strive to create a telehealth environment that centers patient needs and also patient choice. And of course, this is part of our broader direction as an agency in moving to working to eliminate health inequities in Oregon by 2030. We also need to better understand what's working with telehealth and what isn't. And of course, data is still so new in this area. As I mentioned, telehealth was really not very utilized before the pandemic. So we're still really seeing the evidence of how telehealth is working. And third, we know we will expand our impact across the system if we can really coordinate and align as much as possible within our agency, which is the purpose of the work group that I mentioned in the beginning, and also across the health system. Next slide. So just as a few examples here of that work. So as I mentioned, a focus on equity, or the rulemaking process was underway in the fall, and a focus on equity was really strong in that process. So one example here is policy changes we made to increase access to interpreters via telehealth. And as you heard from Kweku's presentation, of course, this is a really critical need. Some of the data we have shows that more than 1 in 7 Oregonians speak a non-English language, and nearly 1 in 20 has a need for sign language interpretation. And as telehealth visits increased, we started hearing more and more stories of members struggling with healthcare interpretation. And Additionally, healthcare interpreters themselves were experiencing financial hits from the transition, and some were suddenly being paid different rates through their role, though really their role hadn't changed, and in many ways had become more complex. And so, what we did here in responding to what we heard is in the rules, in the new permanent rules, CCOs and providers must reimburse interpreters at the same rate for services as if they were provided in person. So interpreters are included in that same pay parity requirement. We also require meaningful access to qualified and certified interpreters in particular, and that includes requiring qualified and certified interpreters for patient consent for telehealth services. And then as Kwaku mentioned, of course, and talked about, that we have the new CCO incentive measure that's really focused on meaningful language access. Next slide. So another area that I touched on a little bit earlier was broadband access. And this map shows the broadband distribution throughout Oregon. The blue colors of the map show the areas of the state that are really well connected to at least basic broadband, and yellow is underserved, and orange and red are both either unserved or just unconnected entirely. And so you can see here that there are really significant disparities in access to broadband around the state. And this is just access to broadband. There's also the issue of affordability of broadband, which even within those blue areas, of course, there are many pockets where people struggle to afford broadband. Governor Brown's proposed budget includes $118 million to fund expanded access to broadband statewide, and we're kind of following that work closely and working as we partnering with the Oregon Broadband Office and others as we can to really see how we can support these efforts to increase access across the state. Next slide. So we also know that we need to closely monitor data and continue to engage members and community partners to understand how we can continue to improve telehealth policies. And so in terms of monitoring the data we have been working to pull monthly reports in the Oregon Health Plan since April, and that's where much of the data I shared earlier comes from. But we are also working on a more comprehensive data reporting and looking at examples from some other states who have done some interesting evaluations recently, including Colorado and North Carolina. Our COVID-related community outreach efforts and our community partner outreach program, as I mentioned, have been really gathering a lot of information and connecting with members and community partners about telehealth experience, and we're continuing those efforts. And we know as we move forward, we really need to work better at engaging populations that are hardest to reach. And finally, we know that, in order to build better policy, we also need better data, and there's a lot of data we don't have right now. And so we have some efforts to increase data. We have new questions. This might interest all of you in the CAP survey, the Consumer Assessment of Healthcare Providers and Systems, that focus on telehealth that just went out, I think, a few weeks ago. The Oregon Health Insurance Survey also includes telehealth questions now. And so it will be really interesting to see that data when it comes back. We also have new telehealth questions in provider workforce surveys, and including questions for traditional health workers and healthcare interpreters. And then we finally are looking at evaluating, doing some multi-state evaluation with several states that we are involved in a collaborative with, California, Colorado, Nevada, and Washington. Next slide. And here is just a look at how we're looking at coordinating and aligning across payers. And I'm not going to go through all of this, but just to note a few pieces, telehealth is in our state health improvement plan. And so we're working, across the agency, but also with other agencies and partners towards goals around broadband and increasing telehealth access. I mentioned earlier a lot of the work we've been doing with commercial insurance and continuing to do that work. We also have, of course, the PEB and OEB within OHA, the Public Employee and Educators Insurance, and working on aligning and collaborating there. And then we have this work group that I mentioned. Next slide. And then finally, we have some work that I alluded to just a minute ago with several other states. So we have 5 states. Oregon has joined with Washington, California, Nevada, and Colorado in a multi-state compact. This is something that happened early on with Washington, California, and Oregon in the pandemic, and Colorado and Nevada joined a bit earlier, and the group and the states decided to focus some of their attention on telehealth. So next slide. The main things that have come out of this work so far is that each state or all states have come together around a common set of principles for telehealth, and you can see them here. And it doesn't mean that each state is moving forward with the same strategies, but that strategies that we move forward with are aligning with these principles. And then finally, next slide. We are really looking at evaluation, as I mentioned. So developing a shared evaluation strategy, and currently are looking at submitting some grant applications for funding so that we could actually have some multi-state evaluation of telehealth. And we're really excited to see where that goes. We're still in kind of the early stages and haven't, of course, submitted anything yet, but would be very exciting to see if we could get some analysis that could help all of us make some more policy decisions. And with that, I know that was a lot. These are just resource slides at the end. And so I'll kind of, you can skip through, Margie, next slide. And I wanted to include as the next slide, just for your information, I'm not going to walk through it. If you go just to the next slide, Margie. This is just a list of all the bills that are currently up in session. And that's it. So thank you very much.
Thank you. I appreciate that. Very informative, a lot of things going on. I want to start with a question I think that was in the chat. You might have touched on this a bit. Divya asked that, or comment, I should say, Divya commented that her understanding is that parity in payment for phone visits is not there, especially for FQHCs and RHCs, even though these are the entities that have disproportionately more people who don't have internet or devices. And kind of wondering if there's a thought on that, what the agency is thinking about, and how you deal with folks that need to rely on phone only, or I should say providers and clinics that need to rely on phone only.
That's a great question, and I'm going to answer and then also see my colleague Diane Quering, I think is on as well. And Diane, please, if you're on and you have any corrections, please jump in and I'll give you a chance. But my understanding is that during the public health emergency, FQHCs and federally qualified health centers and rural health clinics do have the pay parity in terms of Medicaid reimbursement. So pay parity applies to all types of clinics and providers that are able to within their scope of practice, offer telehealth services. And I think after the public health emergency, there are, of course, rules in place, as I mentioned, for general fee-for-service rules and CCO rules. There are also program-specific rules that will need to go into place, and I think we're not at a point yet where we have final decisions on some of those program-specific areas, and FQHCs and RHCs would be one of those. But currently, and as I mentioned, the public health emergency is likely to extend through the end of the year. There is pay parity for phone visits. Diane, please jump in if you have anything to add or correct.
No, Amanda, thank you. Hi, everybody. It's Diane Quering, also with OHA. I'm with the Health Systems Division Medicaid programs. I do know that in terms of those clinics, the FQHCs and rural health center clinics, RHCs, there are some federal level restrictions. So as Amanda mentioned, currently during this public health emergency, the pay parity is there, but there may be some changes depending on what happens at the federal level around those clinics beyond the emergency. So.
Okay, thank you for that. And quickly want to go, I think Lavinia has her hand up, so want to ask Lavinia if she has a question.
Yeah, I have so many questions, but I will, I'm interested in behavioral health because I've heard really positives in terms of access for behavioral health. Did you do a comparison of access to behavioral health services prior to versus now that we have telehealth as an option?
That is a great question, Lavinia. And I don't believe we have data at this point or analysis of specifically access to I'm trying to think actually now that I'm saying that. I'll have to go back to our data reporting and I can certainly get back. And if we don't have that analysis already, I think that's a great idea of what we should be looking at. But we may have something in our reporting and I can get more information to the MAC.
And I asked that question because I think actually what we're experiencing as a provider of some services is that we're seeing different consumers access via telehealth. So it's in addition to, and I would hope that the data will reflect that, and that maybe once we go back to offering both, that you will actually see a significant increase because you'll have those that will do it in person versus those with telehealth. So, and that was one. The other question I had is remote patient monitoring. Mm-hmm. Is that a benefit under OHP, under Medicaid?
It is. There are some caveats, and this is another one where I'll need to go back and actually look really closely at the coverage. Unless, Diane, you have an answer off the top of your head, but I believe it's covered for certain conditions and in certain situations and not sort of across the board. Diane, do you have any more specific information or should we just follow back up?
No, I don't have any additional specifics, but yeah, we can get more.
Okay.
Okay, and again, I asked that question because of for many consumers, having lack of equipment is an issue. I mean, they don't have, especially if you need the video, right? That say for sign language, and that just doing the telephone is not adequate. In that situation, when you have the remote patient monitoring, it can also cover the rental of the equipment, so that we can get that out to consumers. So I'd be interested in knowing whether or not that's a possibility.
Great questions. I will certainly get more information on that.
Okay, sorry.
We're a little over time. Adrienne, is your question really quick?
Well, and Jeremiah, I was just going to say, given that Anna canceled, we do have a little bit of flexibility. I think the discussion is really valuable, so I don't want to stop it if we don't need to. Yeah.
No, that's great. And then we can just do the consumer advisory thing where it's currently out in the agenda.
Super. Thank you.
All right, great. Adrienne?
No, I just wanted to thank you so much for the presentation, and I'm really interested, as I heard Lavinia say, in sort of the additional follow-up on research around access specifically to behavioral health, speaking from sort of our own systems perspective around the impact we saw on expanded patient knowledge of telehealth and telemedicine. We've had some really spectacular feedback from our providers about how it's been so essential to reaching new patient populations. We did have one provider actually tell us that they've now been able to really engage further with a particular family and a mother who we didn't realize was at risk for domestic violence, because she had the ability now to actually manage the care of her children over the phone with her pediatrician, but then also felt safe talking to that provider about other concerns in her household. And so that ability to sort of quickly switch appointment types because we have this new telemedicine access is actually helping us reach patients in new ways that we didn't actually envision. And so this is more just a comment about, we love that OHA is committed to continuing to look at this as an option. And we're more than happy to partner with them on providing more information or stories about how it's impacted our patient population.
Thank you, Adrienne. Really important comments, and appreciate that, and also the willingness to support. We can always use more stories of how this is working for people. So thank you for sharing.
All right. You have a bit more time, Lavinia, if you have any other questions.
Yeah, well, I
want to bring back up. Oh, and real quick, I'm sorry. I just saw.
Oh, you have another.
Why don't you go, and then Lavinia, go ahead, and then after that, we'll have Tammy go.
You mentioned that patients were not comfortable with telehealth in certain circumstances, and I can see that. We've had some folks that we've lost because of that. But what about providers? Because I've also heard from some providers that it's not their favorite way of communicating as well.
That's a great question. It's not something that I think personally, in the conversations that I've been in, and I guess in some of the feedback I've heard and from colleagues, I haven't heard a lot from providers on the challenges, though I'm sure they are out there. I think when we've had in the fall, I mentioned we had a listening session. We held a listening session with the Department of Consumer and Business Services. We actually held a series of listening sessions. One was for members of the public, one was for providers. I would say overwhelmingly at that session there, it was positive feedback, but I would be really interested, Lavinia, in more of that feedback that you may have heard about, some of the challenges on the provider side, and so that we could also get at the root of what some of those might be, in the same way that we are interested in doing that on the patient side. Is it access to technology? Is it challenges with devices? Is it concerns about privacy? That would be really great to understand more.
Okay. All right, I'll stop there.
Thank you. Great questions.
Thanks, Lavinia. And then Tammy, do you have one?
Yeah, actually, I was going to, Lavinia kind of already asked it, but we were under the impression in my agency, because we've been listening to families about their experiences, and you're right, a lot of families really love it, especially those with very complex kids. They have been asking for this for years. And so it just makes so much sense for those very complex kids. But in one thing we did learn, I wanted you to comment on, was we were kind of under the impression that all providers needed to do this. And we were told by parents out in Eastern Oregon that their providers simply say, no, we don't do it. You still need to come in. So I guess my question is, I don't even know if I have a question, but I guess, is that true, that it's not a requirement that the providers can choose to not provide telehealth services? Is that correct?
I believe that is correct. I think that in terms of the, and I might see if Diane has anything to add. I think right now I'm not aware of a requirement that providers, even right now in the emergency, have to offer telehealth services. But Diane, do you have anything more specific on this, either in the rules or other sort of guidance that you're aware of?
No, I think you're accurate in the sense that they aren't required to provide services via telehealth. I think one of the pieces that we put into rule was that if they're not allowed to only provide telehealth services. So a provider, still needs to be able to provide that in-person visit.
And I think to Diane's point, you know, we've definitely heard concerns on the other side of what you're sharing, Tammy, of people that where telehealth does not work for them for a variety of reasons, and maybe, you know, even if they had the technology and access, it wouldn't work, and want to make sure that people maintain access to in-person. But I mean, I think the concern you're raising on the other side, of course, especially right now, is really critical as well, and want to make sure that people have access, I think, to, you know, safe options for that they're comfortable with, and in a place like you're describing, you know, parts of the state that might be difficult in terms of provider access generally. So something that I think we can look into a little bit more to see if we have anything else to add, but definitely not sounds like a requirement that that's the case.
And thank you for that. And Ellen, do you have something quick to add to that point? No? Or you're on mute? Saw your hand come up, so I didn't know if the
Yes,
office had
yes, sorry.
anything they wanted.
If your clients
There you are.
if your clients, Tammy, are having problems accessing the care they need, the Ombuds program has navigated folks through both ends of that maze. Through the end of the maze that says, really, I can't do telehealth, and really, I want to do telehealth. And especially if there's a CCO involved, we've had really good luck working with the CCOs to make sure that providers are providing care that's appropriate for their patients. So please send us those cases if you have challenges. Thank you.
Thank you, Ellen.
Okay. Well, thank you, Ellen. Thank you, Amanda. Thank you, Dan. Appreciate it. Really, really good. Some more, I think, questions in the chat. I think we may follow up with you offline about some parity issues in payment. Really happy to have kind of that on the ground experience. I think Divya was able to verify something while we were on this call, and so we may follow up with you, just kind of some logistic stuff on how this is working. But thank you.
Thank you very much. It was great to see you all.
All right, so we're going to skip the DHS update, and Dave, if you are still on and ready to go, we'd love to have a CCO 2.0 / OHA update.
Great, thank you. Glad to join you. And you can jump to the next slide.
And I'll just share that we'll send out Dave's slides after the meeting. They're actually not in the combined presentation, but we do have those. Thanks, Dave, for getting those in this morning. So I think we have to switch decks.
Okay. Yeah, and I don't know who's operating it, but if somebody can jump to the next slide.
Can you see the slide?
Yeah, I was just requesting to jump to the second slide.
This one?
So Margie, I think this is where you have to go to the other deck.
Can you see it now?
We cannot.
Okay,
No.
let me do it again.
Thank you.
Share.
Yep,
There
looking good.
Okay, great, thank you. So just a couple of things that I was going to touch on today. One is just quickly to review CCO enrollment, then to talk about a new e-board request related to Oregon State Hospital support, comments surrounding the 2022 CCO contract restatement. Believe it or not, that's kicking off. And then a number of things regarding vaccinations, including the CCO data reporting, as well as the health equity plan reporting. So go to the next slide, please. This is just an update on where the enrollment is for CCOs, and you can see that since the onset of COVID, and we put in place that eligibility is no longer terminated unless someone does it voluntarily or incarcerated or is deceased. And so you can see the impact that it's having on our overall enrollment in CCOs. And that continues to go up. And I think there's some other broader concerns about how this is impacting those that would normally have fallen off the enrollment or fallen off coverage eligibility, and what that looks like, as well as what expectations will be once we get to a place where we're making an adjustment once the emergency ends. So a lot of consideration there, but this just to let you know that obviously we're seeing significant increases in the number of people that are covered by Medicaid. So on to the next slide, please. This is a new request that was made of the e-board, and this is out of concern for challenges that we're having with getting people into the state hospital. As you're probably aware, there's been a lot of issues with the access to the state hospital, and we're finding that people are staying on the wait list and getting into the state hospital longer. And beginning January 1st of this year, CCOs now have responsibility for those individuals that are on that wait list, whereas in the past that wasn't a part of their responsibility. And so what we're finding is that whereas putting someone on the wait list to the state hospital might have been a relatively short stay not that long ago, today it's much more of an extended period of time, and often it requires community level treatment to almost substitute for the state hospital treatment. And some of the reasons for that that I've identified here, I think the biggest one is the aid and assist population, which are those that are sent to the state hospital because they're seen as not able to stay on trial. And so this is giving them support in getting to a place where they can actually stay on trial. We've seen a significant increase in the number of people at the state hospital that fell into this category. Whereas in 2012, it was about 17% of the population. Today, it's about 52%. So obviously, that being a priority, you take that population and then add to that those that are there guilty except for insanity, which would be another component of who's housed at the state hospital. That leaves those that are civilly committed significantly reduced. And I highlighted that there, that basically between 2018 and 2020, the number of people in the state hospital that are there because of a civil commitment has been cut in half. And the number of new people being put into the state hospital because of civil commitment has gone down drastically. In fact, in the last, since the fall, there's been a freeze on those additional admissions. And so what we're running into is not only an issue at the state hospital, but an issue in the communities as well. So this request, and this isn't an end all be all, but this is something that hopefully is a stopgap to help us get to a place where we can solve the larger systemic issues, is providing support for adding capacity at the state hospital. And this would support 36 new positions at the state hospital, which will allow us to expand the number of people that can be admitted to the state hospital, as well as 5 new positions to provide intensive support services. And this is at Health Systems Division in OHA. And about almost half of the dollars here are also going to community investments in behavioral health. And there was work with AOCMHP to develop a model of where those dollars would be spent best. Again, this is a step in the right direction, but it's not the whole answer. So hopefully this is something that will give us the ability to address the significant and prominent issue today, and give us time to hopefully lay out a broader plan for handling the broader systemic concerns. Go to the next slide, please. Okay. The next one is the contract restatement. And like I said, the 2022 CCO contract restatement process is starting. And this is a pretty extended process, so that's why we start this early. But basically what we've done so far is we sent out surveys to the CCOs to ask what areas of the contract they're concerned about. And we're doing that in 2 different ways. One is specific to, is there language you want to change? And then the other is, are there certain aspects of the contract that interest you? And I've highlighted some of those at the bottom that we've gotten back from the CCOs. We've just initially reviewed that information we got back. And 2 of the areas that are definitely of high concern or high interest for the CCOs is social determinants of health and equity and behavioral health. And so our intent is at the end of March that we're going to do virtual meetings with CCOs on specific topics. So we're thinking that'll probably be 3 or 4 extended meetings, maybe half-day meetings, where we'll focus on a particular component. For example, we might spend a half a day on social determinants of health. We might spend a half a day on some aspects of behavioral health, that type of thing, with the expectation that we can work through not just the specific language in the contract, but also conceptually what our intention should be and what our expectations are. And so the next step is, as the state legislative session comes to an end in June, obviously there will probably be aspects of legislation that will impact the contract, and so those need to be taken into account. And the goal is actually the requirement is to have the contract finalized by August so that we can send it out to the CCOs for final review and get it signed so that we can put them in place on January 1st of 2022. And just as an aside, this process was kind of truncated last year because of COVID-19. So our hope is that we can actually spend a pretty extensive period of time walking through the aspects of the contract that the CCOs are looking at and have interest in talking about and potentially changing. So hopefully that process will be productive, and that's why we're starting as early as we are. The next slide, please. You can go on to the next slide. There's a lot going on with the COVID vaccinations, obviously. One of the big ones is that we've been working to try and get data related to those who are getting vaccinated and applying it to CCOs. As I think you're probably aware, the alert system that tracks vaccinations doesn't talk to the MMIS system where we maintain the CCO member information. So we have to do this stair step to get there. And our intent is to be able to provide CCOs on a weekly basis a report of who among their members have been vaccinated, and basically when they were vaccinated and where they've been vaccinated. And so we've been working through that. We sent out a sample report about a week ago. We're finalizing internal testing with the hope of getting reports sent out, the first report sent out March 1st. And the idea is that we'll be sending 2 lists. One would be a list of, moving forward on a weekly basis, one would be a list that basically identifies those that had been vaccinated in the past week. And then the second one would be those who are new members and their vaccination status. And a place where that's important, and there's been a lot of discussion of this the last few weeks, is those that might be incarcerated and had received a first dose and then are released. This is less an issue at the state level, but it is a pretty big issue at the county level, because oftentimes those are populations that are being targeted for being vaccinated, but the length of stay oftentimes at the local level is relatively short, so they don't always get that second dose. So this will definitely help CCOs in tracking that. And you see some of the other reasons why this would be important. It gives CCOs that information specific to their members, so they can use that for reaching out. It can allow us to target particular communities or populations that we see as being underserved, and also aligning with providers, and then ultimately giving us the ability to view both demographically and geographically how the vaccinations are being distributed. Go to the next slide, please. Another thing that we're working on that's related to the vaccinations is, I think I mentioned at a previous meeting, we had done a contract amendment that'll fund the CCOs in support for providing vaccinations. And this is non-clinical administrative support. So not the cost of the vaccination itself, but the cost for administering the vaccination. So they can actually pay the providers for that. But the other part of it, part of that amendment was to also focus on how CCOs are addressing equity considerations in vaccination distribution. So, and this is information that'll be going out to CCOs in the next few weeks, providing specific guidance in what the expectations are. So what we did is we took the the health equity plan that the CCOs had submitted at the end of 2020, and identified areas of that health equity plan as the basis for the information that we want back, or the reporting that we'll be seeking from CCOs relating to vaccination distribution. And the areas that we were focused on is the demographic data, culturally and linguistically appropriate services, and then member education and accessibility. So each CCO in their health equity plan had submitted actions that they were going to take in each of 8 focus areas. And so what we'll be asking is that as it relates to the vaccination distribution, how is that plan being applied, and how would that be supporting the efforts in these 3 focus areas in distributing vaccinations in an equitable way. So I think I don't know if I have one more slide, or is that my last slide? I'm not sure. I guess it's my last slide. Yeah, I guess that's my last slide. So I'll open it up to any questions on, I guess, anything that I've covered here.
Thanks, Dave. Any questions? I think there's a hand up from Lavinia.
Hi. So I was wondering, do you have counts on how well we are doing vaccinating the different priority groups by county?
I know that I don't, but I mean, that's hopefully where we're going to get to with this reporting. It'll give us the ability to actually start having those conversations. Because right now, for example, we had, and I don't know if this is where you're going with it, but we did have a recent push to focus on those that were in the DDS population. And so there wasn't an easy way to do that and then take that information and then apply it and distribute it to CCOs to support this effort. And where we'd like to get to is that we're actually providing reporting data so we can simply say, this population is being underserved, and based on the information we've provided, here are those within your particular CCO that have been vaccinated or not vaccinated. So that's, I guess, an answer to your question. I'd say that we aren't quite there now, but that's our intention to get there through this reporting. I hope that answers your question.
Yeah, but it does. It does. Thanks.
And then a question in the chat from Tammy. She's asking if the CCO equity plans are available online for the public to see, and if not, probably for members of Medicaid Advisory Committee. Is that possible?
Yeah, I don't think that they're online yet. They're still under review, and I think the expectation is that that review is going to be completed within the month of March. And so at that point, they'll probably be made available. But I'll probably be able to give you more on that. But I'll follow up on the specific timing of that, because just what I've seen of them, they're really valuable documents, and I think they're pretty well done in terms of laying out the expectations or the plans for individual CCOs and how to address many aspects of health equity. And a lot of time was spent on trying to figure out exactly what that'll be. It was a little over a year ago, that was kind of more of a conceptual idea. We really should have a health equity plan. And a lot of work went into that to actually turn it into something real and something valuable. And so yeah, I think that when those do become available, I would strongly recommend taking a look at them. But I'll get the specific information so that you have some sense of when those will be made available.
Okay, great. And then I think final question. Thank you for that, Dave. And Miguel, do you have something?
Well, I think he partially answered, because my comment is that although the health equity plans are very detailed on these aspects, demographic, appropriate services, and member education around their services and what they need to know and how they can request. So the big challenge for underserved minorities in this emergency is that we know the challenges about having the right demographic data, and then I see difficulties really how to project, how to use this data to identify inequities on vaccination. So that it seems like difficult to achieve without the collaboration of community partners. The community partners and the clinics, obviously, they know their members and they really can get better idea of where are the missing points that we have, and for those communities, so minorities, underserved communities, the usual way to get data or to communicate with them is person to person, and that so the support that OHA can continue to provide to community partners to do that work is crucial to have success on this moment. So I'm talking about calling the people that you have and to help them understand why they need to vaccinate, how to make an appointment, answer their questions, and that happens only person to person. So that's a big challenge we have ahead.
Yeah, I totally agree, and I think you make a good point that this is one step in the process, but there's several steps that need to be a part of this, and our hope is that if we can identify those that are being underserved, then encourage the CCOs to provide direction on how best to reach out. And like you said, I think there are community organizations that provide one of the best means to do that, to allow us to get to the place, get from identifying to actually supporting and ensuring that people are getting vaccinated.
Okay. So thank you for that, and thank you, Dave. Lavinia, I know you put a question in the chat about COFA population and number of anticipated becoming eligible for Medicaid. We might try to answer that by email, Dave, unless you have a really, really quick answer to that. I know we're a bit over. I think we're a bit over time, Jackie. I'm in the space-time continuum now, so I have no idea.
Yeah, I'll get you the exact number, but I'm thinking it was somewhere in a few thousand, but I'll get you the exact number.
So we can follow up. Yes, we are a bit over time. I want to check in with Lisa and Veronica, who I think might have a hard stop at 11. And so I think the decision is, should we take a short break of 5 minutes, or should we plow through the quality strategy discussion and then take a short break? Lisa and Veronica, I don't know if you could weigh in on that.
Hi, this is Lisa. I do have to leave at 11. I'm not sure about Veronica. I have another training to do with some hospitals at 11. So unfortunately, I have to kick that off.
So MAC members, would you be okay getting through this agenda item and then taking a short break? We have a little bit more flexibility on the back end of the agenda.
Yeah, sure.
Thank you
That's
very
fine,
much.
Jackie. I might turn it over to you to help you and Leslie to help facilitate at this point.
Super.
Thanks,
Jeremiah.
Thank you
Thanks
so much.
Jeremiah.
Yeah.
All right. So we thank you, MAC members, for being flexible. And is Veronica on? I can't see on my screen, so I apologize. So we've got Lisa Bowie here. They are coming back to follow up on the quality strategy update that they provided in December and give the MAC members some time for discussion. They are here sharing information about the OHA review process for notices of adverse benefit determination. So I will turn this over to you, Lisa, and thank you very much, and Veronica as well.
Yes, we'll go ahead. I'm not going to speak to all the slides, and we'll get to kind of more of an interactive conversation. But again, we're just recapping the statewide quality strategy, specifically give you some information on the appeal and grievance logs, and then where we, again, are really wanting your input. Next slide. Just a reminder, there's a quality strategy. It comes from our 1115 waiver for the Oregon Health Plan. It obviously is to drive quality across the Oregon Health Plan. And what is the role of the MAC is probably really important for this discussion, which is you really get to help us inform the direction of the quality strategy updates and the accountability methods for the implementation of the strategy. So that's where we are today. Next slide. This is just, again, the CCOs have their own transformation quality strategy. We went over this in December, so I am going to skip it. But again, what the CCOs are doing, how it informs what we want to monitor, this is just that context. Next slide. Veronica, are you on?
Yes, hi, I'm here.
You want to cover this one?
I literally just jumped on, Lisa, so I apologize.
Why don't? That's okay. We're gonna circle back to this, Leslie, if you don't mind, and we'll get to the NOBD. That's a hard one for me to say. Let's go ahead and advance the slide and get to the input, and then we can shave like 5 minutes for NOBD. Let's go back to slide.
Thank you, Lisa.
Back to. One more. Sorry. One more. There we go. Perfect. So here are some updates that are going to happen into the Oregon Health Plan Quality Strategy. These updates will be made by May 21, 2021. So there's still time for us to engage going forward. But here's some changes that are going to be included. What I want to let you all know is the existing quality strategy was put forth when we submitted the last waiver, so 2018. And usually you update it every 3 years. That's the actual update of the strategy. There could be work plans and accountability, but as far as the actual updating, it was in 2018. So to that reason, here's why we're going to make some changes to it. We're going to obviously include the OHA's 10-year goal of, again, to eliminate health inequities by 2030. We're going to align the strategies within the overarching quality strategy to the CCO 2.0 priorities that we're all operating under. Again, this was submitted prior to the CCO 2.0 contract, and so we're going to just kind of do some cleanup and align. We're going to also include the state health improvement plan strategies for 2024, which again dovetail nicely to the CCO 2.0 priorities. So just again, some cleanup and bringing it current. The other thing we're going to have to do to the quality strategy is align to the November 2021 federal rules. So the strategy has to meet state and federal regulations. So there's a little bit of cleanup to do on the most recent rules, and we can give you more detail on those if you'd like. And then one of the things that we're doing that is outside of, the state health improvement plan and rules is really align and update the quality strategy to some of the quality payment programs that are out there. You might hear about the incentive measures. You also probably hear about some other incentive programs. We want to basically, again, those incentive programs or payment programs are to drive quality. And so we're going to update the strategy to include those. So those are the changes we know about. Let's go ahead and go to the next slide. So here's where you all can kind of come in. What additional information from the quality strategy? So there's the first question, which is what information in the existing strategy do you want us to come back with you on to give a deeper dive? Because probably annually, just kind of giving this massive amount of information, it's hard to digest. So we really recognize that we should probably do this more frequent. And what frequency do you want that? And again, what topics, if we wanted to rank it, and we can talk about doing a survey, or if it's just open dialogue to get to the first bullet. The second bullet is on the actual changes. What level of engagement? I gave you some high level bullets of what's coming for the May version. How do we want to get that input from you all? Also, what level of detail do you want? That's kind of what the second bullet's getting to. So we have a point here, Leslie. We can do some dialogue, and then we can go back to NOBD, or we can do NOABD and then come back. I'll
Lisa,
you all.
I think it might be good to first do NOABDs and then come back to dialogue, because maybe some folks, I think it'll help for the dialogue. And I apologize, when I jumped on, I was actually looking at, I have a little bit of a lag on my side as far as the presentation. So I was looking at a different slide and I wasn't sure what you were talking about. So I apologize for that. So if we can jump back to the NOABD slide, we covered some of this last time when we chatted with you all, but what I'd like to highlight are some of the recent updates, I guess, to this work. So as I mentioned last time, just as a refresher for everyone, the Quality Assurance Unit is starting to do evaluations of the quarterly appeal and grievance log NOABD samples that are submitted. And so NOABDs stand for Notice of Adverse Benefit Determination. Every quarter we receive a sample of 20 from each CCO and DCO, our dental care organizations. And yes, if we can actually go back one more slide.
Perfect.
There we go. Thank you. So we have a sample of 20 that we receive on a quarterly basis from CCOs and DCOs. We reviewed the Q2 submissions, as I mentioned last time. From those Q2 submissions, we issued evaluations or feedback to the CCOs in terms of some of the findings that were noticed as we were reviewing. And many of the findings were really around inclusion of the appropriate language in the NOABDs. So when I say appropriate language, I mean the required language that is in state rules and at CFR level, at the federal regulatory level. There are standards for what language needs to be included in these NOABDs. And so we found that there were quite a few gaps in terms of these notices really having the appropriate language included in the notices that are being issued to members, which of course is a concern because that in essence, could potentially mean that our members are not receiving their due process because there may be language that is missing from those notices. So part of the goal here is to ensure that all CCOs and DCOs update their notices to include all of the required language that has to be included in those notices. The future state of this review is that we will hopefully get to the point where everyone has the standard language included in the notices, and then we will be shifting our attention to review for appropriateness in terms of appropriate denials and accuracy of those denials that are taking place. We asked after this Q2 feedback or findings that were issued to the CCOs and DCOs, we asked specifically the CCOs to submit work plans to address those findings that were included in the Q2 review. We received those work plans mid January and are reviewing those work plans currently, and will be reaching out to any CCOs that have not clearly defined how they are going to resolve the particular findings that were included in their Q2 review and within what time frame. The other piece that I would love to call out is that we are, as part of the process to standardize the language that is included in these notices, we're convening a notice template work group. That work group will have various representatives from CCOs and DCOs, and that work is kicking off in March. I believe it's March 9th, to be exact. And that work group will focus on developing standard notice templates that can be adopted by both CCOs and DCOs. So that's part of the work that is going on right now around notices, particularly with the review of the NOABD samples that are coming in. And I'll hand it back to you, Lisa.
Great. So that is a lot. So we got some hands already, it looks like.
Yeah.
Yes, we do. We do have a couple of hands up. Miguel?
No, sorry.
Okay.
It was from the past presentation.
All right.
Sorry.
So go ahead and put your hand down there, and then Karen.
Yeah, so my wife just received a notice of adverse benefit determination. And the issue we had is we both have college degrees. I have 2 master's degrees. And I think it had the appropriate language. It was not plain and understandable. And as a consumer, that's much more important that somebody with my background and having spent the last decade being actively involved in healthcare in the state of Oregon, that I get this notice and I can't understand what it's saying. And so for me, I don't care if it meets, as a consumer, I don't care if it meets federal guidelines. What I want to know is, what does this mean to me?
Yeah, great point. Great point. And that is part of the requirements. It actually is that these notices are understandable and are explained in a way that is comprehensible to our members that are receiving these notices, because you're correct that a lot of the language that goes into these notices, is very difficult to decipher. And so that is a balancing act that we are going to have to figure out how to strike when we convene this member notice work group, to make sure that the notices, are include the appropriate language, the required language, but also the information is delivered in a way that is understandable, that is straightforward, and that is at that 6th grade reading level.
So how are you evaluating that in your March work group? Do you have consumers who are part of the work group that are going to help evaluate what it is to be understandable?
So we do not have consumers that are involved in this work. As I mentioned, the work group is largely composed of CCOs and DCOs, where we will get some of that part of the process will come in when this group has basically finished its work in terms of the content of the notices. We will engage MEOC, the Member Education and Outreach Committee, to do some of the work around making sure that these notices are actually understandable and are at that 6th grade reading level. So that's how we'll be getting at some of that through our engagement with MEOC. They have a long history of actually doing this work. And working on the notice templates, in essence, and helping to make them a bit more understandable.
Veronica, do you know if MEOC would include a public comment period? And I'm sorry, I jumped the queue.
Okay.
I actually don't know that, Jackie. We have, I don't know that. I have not participated in MEOC enough to know that there is a public comment period, but I don't believe there is, just from the conversations that I've engaged in. I can definitely make sure that we figure that out. Tiffany Reagan, who is previously was on our external relations team, has moved on to the quality assurance team, has done quite a bit of work on this piece. And I do want to, I guess, reinforce that the member experience and the members' ability to understand what is in these notices is definitely something that we, quality assurance, will be taking into consideration, and making sure that whatever the final product is out of this work group, that these notices are clear and understandable for our members.
All right, being mindful of time, Lavinia, your hand is up, and then we'll move to Tammy.
Thank you. It's related to the same thing that Karen was talking about. I just wanted to know, understand that all of the CCOs, once you agree upon some standard language and you make sure that it is understandable, that it'll be used consistently throughout all of the CCOs. Is that what I understand?
The hope is that everyone will adopt these standard member notice templates. We will not be requiring them to adopt them, but it's probably, you know, I imagine that many will be actually adopting these notice templates. I've heard several CCOs that actually have stated that they would love to have some standardization across all CCOs as far as the language that is included in the notices in the scenario that you have one member moving from one CCO to another. So I would be hard pressed to say that, you know, we would not have widespread adoption.
Okay, but that's the objective, is to try to have standard language out there. Okay, thank you.
All right, Tammy.
Yes, hi. You know, I've seen some improvements over the years. We are many years into this experiment, and I have seen some improvements with the understandability of the handbooks that have gone out. So I know it can be done, but my specific question is this going to be a really long process that will be in, how long will this process take, first of all? I appreciate Karen's question about consumer group, and although I can't speak for Lavinia and Jackie's committee, but there is a consumer subcommittee within this body that I would offer, if I could, or at least put on the table. I'd like to ask us to think about, could we play a role in that, because there are consumers there. And then just lastly, why would this not be a requirement? Is that because of the contract timing and it would have to wait until a new contract in order to require it? I guess I'm not understanding why something quite simple is plain language, because plain language was a huge piece of the Affordable Care Act, why it would not be required.
So a few different questions in there, and hopefully I can remember all of them. Feel free to let me know if I left anything out. So as far as the completion or the timing for completion of the work group, we at this time we're in the planning stages. We're if I'm recalling correctly, my leads on my team who will be leading this work group have told me that it probably will wrap up in about a month and a half to 2 months. So it's not, you know, a protracted time frame here in terms of getting this work done. There's really an incentive to get it done relatively quickly because we want to make sure that all of these issues that we found in our Q2 NOABD reviews, you know, regarding language being missing from the notices is addressed, and this is one way to be able to do that. So at the end of this process, the CCOs and DCOs will have to submit their notice templates for the NOABD and NOAR, the Notice of Appeal Resolution, to us for approval. And so that will, you know, we'll be able to, at that point, I think, see how widespread the adoption was of these notices. We are not making it requirement because there are particular notices that actually there may be a need to modify those notices. So it may not be a, you know, complete adoption of the actual template notice that is provided to us. It may be, you know, there may be some modifications. So for example, pharmacy notices, notice of denials are on a very different time frame than your typical service denial notice. those have to be responded to within a much shorter time frame. And so the systems that the CCOs use to generate some of these notices have to be modified and adjusted in certain ways in order for them to meet those timing requirements. So we're not making it a requirement across the board for that reason, but I do want to point out that the requirement for making sure that the language is understandable and comprehensible and in plain language is a requirement that is separate from them adopting the actual notices themselves. As a full adoption of the language that is in those notices. I anticipate that some may want to modify the notices to some degree based on the type of service that is being denied. So I hope I hit everything. I'll take your suggestion, Tamara, about involving potentially, the MAC consumers in that review process. I'll put that forward to my team in particular to think about, and we'll see if there is a way to be able to engage you all in the review of these notices.
And Veronica, it looks like we have one more question from Ellen.
Sorry, having problems getting my microphone off mute. Last time I was involved in developing these notices, it was the Oregon Law Center that helped develop the templates and our own review of the NOABDs that the Ombuds program gets because we work with clients. A lot of that language is very similar. The language that is not possible to script is the language that Karin was referencing, which is the reason for the denial. And it is that all of us have had challenges understanding. Sometimes there are huge, there's a citation that includes the entire OHP kind of OARs, which doesn't do anything for clients. So I really appreciate what MAC is doing and offering here, the Member Voice Subcommittee, to help everyone understand specifically that part of the denial, how you might enable folks to understand actually why they are being denied this service and what their options are. And would also say that MEOC is a CCO contractor subcommittee. I believe that like all of these contractor committees, there is time for public comment. I'm happy to send you, Jackie, a link to the MEOC page so you can share it with MAC members who would like to attend.
Thank you.
All right.
And Jackie,
you.
I have to jump off to another meeting, so I apologize, everyone. But if there are more questions, please feel free to forward those over to Jackie, and I'm happy to answer them after the conversation.
Thanks, Veronica.
All right. So Jackie, it looks like we're at about 11:08. Break time, 5 minutes, 10 minutes. Let's do like the airlines and make up time. 5-minute break. All right. So everybody,
that sounds great.
Feedback. 5 minutes. All right. Thanks, everybody.
Thanks, Leslie.